As you know, new BTKIs were tested in 2 large randomized studies comparing against ibrutinib. Ibrutinib versus acalabrutinib and ibrutinib versus zanubrutinib. Only Alpine study where zanubrutinib was tested showed a PFS advantage of 66% versus 54% at 3 years, and also a better overall response rate. In abstract 4632, zanubrutinib was tested for patients that were intolerant to acalabrutinib, and that, based on the studies, happens in 15 to 23% of patients. They enrolled 35 patients that were intolerant to acalabrutinib, and out of these 35 patients, only 5 had to stop zanubrutinib for adverse events. 2/3 of acalabrutinib-related adverse events did not recur when patients were switched to zanubrutinib. In this study, overall response was excellent with 94%, and the conclusion of their study is that acalabrutinib can be safely switched to zanubrutinib in case of intolerance. The major news in the Congress regarding CLL were in the main interest in limited duration treatment. As you know, in first line, ibrutinib venetoclax was approved by European institution in 2022 following the CAPTURE study. And during this meeting, a few abstracts were presented. The first one I wanted to share with you is 1874. It's an independently sponsored study looking at relapsed refractory CLL, where they tested zanubrutinib venetoclax for 15 months fixed duration. The early results are presented in the meeting, and only 9 patients completed 15 months treatment. Out of these 9 patients, 8 are in CR off treatments. In 22 patients evaluable for response, there was an overall response rate of 95%. So it's really encouraging to see that the combination of a Bruton kinase inhibitor and a BCL2 inhibitor can be used for a limited duration of time. The second abstract I wanted to talk to you is 1012, and it tested sonrotoclax, a new BCL2 inhibitor with better selectivity and better potency than venetoclax in a phase 1/1b study. The dose escalation study was done in patients treated in first line for CLL, and zanubrutinib was given first for 8 to 12 weeks at standard dosage, and then sonrotoclax was introduced as a ramp-up to the final dosing of 160 for one group and 320 milligrams every day for the second group. 112 patients were enrolled in that study, and these were fairly unfavorable patients with 51% unmutated IGVH, 20% of P53 mutation, and 7% of P17 deletion. The 18 months follow-up is presented, and they concentrated on adverse events. They had 40% neutropenia, 38% contusion, 30% had COVID, 29% had diarrhea, and out of these side effects, 78% were grade 1. The only grade 3 or more side effects were 2 patients with febrile neutropenia, and they mentioned that patient on COVID stopped treatment during COVID treatment. The results are quite interesting, with an overall response rate of 100%, a CR rate of 41%. The median time to response was quite rapid, was 2.6 months, and the median time to CR was 8 months. These results really leads the way to the phase 3 study that was announced at ASCO this year, which is called Celestial, and will test sonrotoclax and zanubrutinib versus the standard of care of venetoclax obinutuzumab for the short-term treatment. Finally, I wanted to talk about an abstract presented for relapse refractory CLL, and it's abstract 885. There's a great interest in a new class of BTK treatment, which is called BTK degraders. They use the ubiquitin proteasome pathway and are active on all mutated or unmutated BTK proteins. The small protein that was presented here is BGB 16673, and it's a dimeric protein that puts together the BTK with E3 protein that provokes ubiquitination of BTK and degradation by the proteasome. The study is a phase 1/2 study called Cadence, and they enrolled 49 patients in relapse refractory CLL that had at least 2 prior treatments. The dose level was from 50 to 500 milligrams, and they were also quite bad patients, with 63 patients that had P53 mutation or deletion 17, and 82% that were unmutated IGVH. The follow-up presented here is 8 months, and they concentrated on adverse events, mentioning that grade 3 or more adverse events were neutropenia in 20% of the patients, and pneumonia in 10% of the patients. Overall response rate was 78%, and they conclude that tolerable safety profile and encouraging deep overall results in this population which were heavily treated with BTK, mostly resistant patient.